Today we'll go with dental management of medically compromised patients. So what are the medical conditions predisposed for complications? First one is cardiac conditions. Cardiac conditions means condition related to cardiovascular system or heart. So if the patient is having prosthetic valves and joints, infective endocarditis, then single ventricle states, valve disease, transposition of arteries, hypertrophic myopathies, then hypertension, ischemic heart disease, arrhythmias, respiratory conditions like pulmonary, then asthma, tuberculosis, liver disorders like hepatitis or alcoholic liver disease, and in GI disease, acid peptic disorders. Then sexually transmitted disease like gonorrhea and syphilis, HIV related conditions, diabetes, adrenal insufficiency, thyroid disease, hypersensitive reactions, bleeding disorders, behavioral or psychological disorders, neurological disorders. So the first thing is the physical evaluation. A general survey is taken, the vital signs are taken, clinical and lab tests. If doubtful, yes, it should be taken. The outward patient appearance of a patient can be given in sight of general health and well-being. This includes assessment of the exposed body areas such as skin, nails, face, eyes, nose, feet, etc. The way wasted, cachexic, lethargic, ill-kept, dirty clothing and hair body odors, gait, build, posture, breathing and breath smells, they should be observed. So skin is the largest organ of the body and large areas are exposed and easily available for inspection. So if you see cyanosis in the skin, then may suspect cardiopulmonary conditions. Yellowing means liver diseases. Potassium means blood discharges, pallor in anemic patients. Nails are also available for inspection, such as clubbing in cardiopulmonary diseases, whitish coloration in cirrhosis, and this yellowish in liver dysfunction and malignancy. In face, chorus features such as acromegaly, and then moon faces like in Cushing syndrome, dull and puffy face in myxedema, loss of wrinkling in CVE, then flushing in cardiac valve disease. Eyes and nose. Eyes are sensitive indicators of systemic conditions. So a wide eye stare is in hypothyroidism, xanthomathus in hypercholesteromies, then icterus in liver disorders, red conjunctiva is Zika syndrome, and in nose is observed for laborious breathing and all. You can check the breathing and all. So neck, yes, node enlargement should be seen. Thyroid, for thyroid, neck nodes, then vascular deformities. Vital signs recording has two benefits: establishment of the baseline value of future comparisons, identify abnormalities, diagnosed or undiagnosed. Vitals, in vitals, pulse, blood pressure, respiration, temperature, and weight, they have different calibrations and their different outcomes. Then clinical lab tests aids in diagnosis of suspected diseases, screening high-risk patients, establishing normal baseline values before treatment, addressing the medico-legal considerations also. In cardiac conditions, infective endocarditis, then microbial infection of heart valve or endocardium, most often related to congenital or acquired cardiac defects. Endocarditis occurs when bacteria enter the bloodstream and infect the damaged endocardium or endothelial tissues. Infective endocarditis and clinical features are systemic conditions, history, fever, chills, malaise, weakness, weight loss, arthralgia. Then signs and symptoms are fever, pallor, splenomegaly, and findings are anemia, ESR, increase, positive blood culture. In intravascular lesions, history is dyspnea, chest pain, stroke, abdominal pain, painful extremities. Signs and symptoms are murmurs, signs of cardiac failure, pitashi, raw spots, ulcer nodes, myotic aneurysms, ischemias. Findings are hematuria, abnormal CXR, and culture, etc. The immunological features, the history of arthralgia, myalgia, or tenosynovitis is there. And signs and symptoms are arthritis, signs of uremia, vascular phenomena, clubbing. Findings, proteinuria, hematuria, cast, uremia, increased G globulins, Rh factor, decreased complement immune complexes in serum X, and staphylococcus, then staph antibodies are there. In dental management, medical consideration, then antibiotic prophylaxis and prevention should be taken. So the frequency of bacteremia in various dental procedures, in extraction, the chances are 50 to 85%, periodontal surgery 88%, scaling 8 to 80%. So it's a vast range according to the procedures. It's a vast range. Even in toothbrushing, it is 0 to 40%. Then wooden cleansing devices 20 to 40%. Irrigation devices 7 to 50%. So antibiotic prophylaxis should be considered when the following three situations exist. A complication is common but not fatal one. A complication is rare but mortality is high, and a single microbe is implicated. Such an ideal situation, however, does not exist. So in infective conjunctivitis, the prophylaxis is recommended for amoxicillin 2 gram orally 1 hour prior to the procedure for adults, and 50 milligram per kg body weight for children. Alternate regimen is if the patient is sensitive to penicillin, then clindamycin and erythromycin. Clindamycin 600 mg, cephalexin 2 grams, erythromycin 500 mg, or orally 1 hour prior to the surgery. In children, clindamycin 10 mg per kg or cephalexin 50 mg per kg and erythromycin 15 mg per kg orally 1 hour prior to the surgery. As American Heart Association recommends, when the prophylaxis is not needed in post-op suture removal, in non-intraligamentary local anesthesia, impressions, shedding of primary teeth, X-rays, and restorative dentistry. In hypertension is another thing that you will commonly encounter while in extraction patients. Sometimes it leads to more bleeding also. So it is an abnormal elevation of the arterial pressure that can be fatal if sustained and untreated. The adults are sustained diastolic BP of 90 millimeter of mercury with the greater, or systolic BP of 140 millimeter of mercury or greater is considered abnormal. In hypertension, classification of blood pressure for adults, category systolic or diastolic. The systolic optimal is 20 by 80. Then in normal, 130 to 84 is normal. High normal is 130 to 138 or 140, we can say. And this is the limit one. Okay, and then 84 to 88. Now in hypertension, stage 1, stage 2, stage 3. Stage 1 is having a limit of 160, 140 to 160, then up to 100 diastolic. Stage 2, 110 diastolic and 180 up to 180 systolic. and 180 and above in stage 3. So in hypertension, signs and symptoms of hypertensive disease, early signs or advanced signs. In early signs, increased blood pressure readings, narrowing of retinal arterioles, retinal hemorrhages. In advanced signs, papilledema, LV hypertrophy, hematuria, proteinuria, CHF, renal failure, and angina are the signs of advanced hypertensive disease. Some other symptoms are like occipital headache. Patient will often complain of this. Then failing vision, ringing of ears, dizziness, weakness, and tingling of hands and feet. In dental management, medical consideration, use of vasoconstrictors, treatment planning and modifications are there. Recording of BP, baseline and diagnosis, physician referral. Yes, physician opinion is mandatory for patients having any medically compromised condition. Then stress reduction protocol should be there. A good rapport with the patient. Patient should feel comfortable in your clinical setup. Then avoid long appointments. Use pre-medications such as benzodiazepines. Then gradual changes in chair position to avoid orthostatic hypotension. Use of vasoconstrictor up to 0.04 mg of epinephrine is safe in moderate hypertension and provided done with the aspiration. Relative contraindication includes uncontrolled hypertension, refractory arrhythmias, then recent ISD, CVE, and CABG with hyperthyroidism. The symptomatic coronary atherosclerotic heart disease is referred as ischemic heart disease. So this is the next topic. So in erythropoiesis is the thickening of the intimine layer of heart arterial wall caused by accumulation of the lipid plaques. So internally it is clogged. So lead to angina pectoris and myocardial infarction. Dental management is take early morning appointments, comfortable sitting with a relaxed atmosphere, pre-treatment vital signs, then GTN readily available, then stress reduction protocol, limited use of vasoconstrictor, post-op pain control. Open communication about fear and concern. It is a general stress protocol management, short appointments, morning appointments, preoperative vital sign sedation, and short-acting benzodiazepine prior, night, and hour before the surgery. So profound anesthesia, use of topical spray, intraoperative sedation, educate post-op and pain control, and patient contact. The next is bronchial asthma. Asthma is a chronic inflammatory disease consisting of recurrent episodes of dyspnea, coughing, wheezing resulting from hyperresponsive of the tracheobronchial tree. The dental management is identification by history, type, mild, moderate, severe, PPT factors and frequency, align factors and medications, avoidance from unknown aggravating factors. In dental management, medical consultation is important. Patient to bring inhaler at all appointments. Drug consideration, avoid aspirin, NSAIDs, barbiturates, erythromycin, and local anesthetic consideration should be there. Supplementation of steroids and in chronic cases. So be ready with this also. Okay. So in asthma, inhaler to be bought by the patient is must in every appointment, and then you have to avoid some various drugs, and third thing is supplementation of steroids. Okay. Recognition and management of acute attack, inability to finish a sentence in a breath, tachypnea more than 25, tachycardia more than 110, then accessory muscle uses, paradoxical pulse, administering of fast-acting bronchodilator, oxygen, and if needed, epinephrine. Steroid sting because steroid will take long time. Classification of next is diabetes. In India, most of the patients who are coming to you are either they have diabetes or they have a hypertension. They are hypertensive patients. So hypertension and diabetes are most common here. So we have various type of classification. Type 1 immune mediated idiopathic, and in type 2 insulin resistant with related insulin deficiency. So in type 1, B cell destruction of or defect in B cell is usually leading to the absolute insulin deficiency. Presence of islet cells or insulin that can identify the immune response process leading to B cell destruction in immune mediated, and in idiopathic no evidence of any autoimmunity. And in type 2 insulin resistant with related insulin deficiency. Other specific types are genetic defects of B cell or insulin action, pancreatic disease, adenochronopathies, malnutrition, drug or chemical induced diabetes, then impaired fasting glucose, then abnormalities of fasting glucose, in gestational diabetes, any degree of abnormal GTT during the pregnancy. So in type 1, type 2, frequency or age of the percentage of the person with diabetes in type 1, 5 to 10%, and 90 to 9%, and 90 to 95% are type 2 clinical pictures. Then age of onset is 3 to 15 and 40 and plus. Body build normal or thin in this type 2 obese. Severity extreme to mild. Then insulin in type 1 almost all, and in type 2 25 to 30% only. Plasma glucogen in type 1 is high and suppressible, and in type 2 it's resistance. Ketoacidosis is common in type 1 and uncommon in type 2. Oral hypoglycemic agent, few respond to them. In type 2, there is a good response. Ketoacidosis, common in type 1. Again, it is not common in type 2. Complications, 90% in 20 years in type 1. And complications are less common in type 2. Family history, type 1 common. And type 2 more common. Then genetic locus, chromosome 6. And in this type 2, chromosome 11. Insulin receptor defect not found in type 1 and found in type 2. Sign and symptoms of insulin reaction in mild stage, moderate and severe stage. So hunger, incongruence and uncongruence. Then in mild stage, weakness, uncooperative, in moderate, and tonic-clonic seizures in severe stage. Tachycardia, pallor, sweating in mild stage, and blemishes, lack of judgment or poor orientation in moderate stage. Then hypotension, hypothermia, and pulse rapid and 3D in severe stage. The dental management, non-insulin dependent patient, all dental procedures may be performed unless the presence of complication of the disease is present. In insulin dependent patient, no contraindication for any procedure. Morning appointments are the best. Usual insulin and meals on the day of the surgery. Then patient advised to inform if symptoms of insulin reaction occurs and any care thereof. In need of an extensive surgery, consultation with the physician regarding the dietary needs during post-op period, and antibiotic prophylaxis for the brittle diabetes. Now, bleeding disorders, sometimes they are very crucial. The bleeding disorders are the conditions that alter the ability of the blood vessels, platelets, and coagulation factors to maintain hemostasis. The classification is disorder of coagulation, hemophilia, inherited and acquired, liver, nutritional, anticoagulant drugs, anti-IC. Classification is thrombocytopenia, primary idiopathic, secondary chemical, physical, and systemic. And a non-thrombocytic purpura is vascular wall alteration or platelet disorder function. A fibrin forming coagulation system, and this is the casket. So in 1 to 2 seconds after this platelet adhesion, then with the help of ADP, platelet aggregation is there. After that, platelet release and platelet plug is formed. Fibrin formation is there. 3 to 5 minutes consolidation is there. Then retraction time and 5 to 10 minutes for fibrin stabilization. So medical management conditions like von Willebrand disease and defection in the von Willebrand factor, and treatment is of factor 8 treatment is given. Then in hemophilia A, factor 8 is defected and treatment of factor 8 and AGG is given. Then there are number 1 TCP, number 2 TCP and liver disease. So autoimmune destruction, deficiency of platelets to some cause, and multiple coagulation factors are there. So platelet transfusion, vitamin K, prednisolone platelets are, these are the medical managements. So we can just have a review of that. Our dental management is the patient identification and history symptoms should be there. Bleeding problems after wound surgery or extractions. So medication that may cause bleeding are to be avoided. Presence of the illness with associated with bleeding problems and spontaneous bleeding. So pre-operative consult consult thoroughly, confirm the diagnosis, status of medical condition, coagulation profile, type of surgery plan, need for dose of reduction of anticoagulants, and need for ramping up the coagulation factors. The dental management is operative. Use good surgical techniques, control bleeding by local means, pressure packs, gel form, thrombin, oxycell, and surgicel. In microfibular collagen should be there. Tranexamic acid, most commonly we are using tranexamic acid. Splints and hospitalization if required. Post-operative, avoid aspirin and NSAIDs, and see the patient after 48 hours to observe healing is there, infection if give antibiotics if infection is present, and check for the bleeding if any. Next thing is thyrotoxicosis. So in thyrotoxicosis is referred to the excess of T3 and T4 in the bloodstream. These excess may be caused by ectopic thyroid tissue, means grave disease in MNG and pituitary disease, etc. So it has various symptoms in skeletal and cardiovascular system. Like in cardiovascular system, it has palpitations, tachycardia, arrhythmias, cardiomegaly, and ISD. In skeletal system, increased bone turnover, increased rate of resorption and osteoporosis. In CNS, anxiety, restlessness, sleep disturbances, emotional liability, impaired concentration, weakness in tremors. In GIT, weight loss despite of increased appetite, then decreased absorption of vitamin A, pernicious anemia, and increased risk of diabetes mellitus. In skin, arrhythmia, hyperpigmentation, thin, fine hair, soft nails. In eyes, retraction of upper lids, exophthalmosis, then corneal ulceration, ocular muscle weakness. So the dental management is detection of the disease and referral to the specialist. Then avoid in poorly managed cases surgical procedures, acute infections, and vasoconstrictors. It include of gingival retraction cords. Under control cases, avoid oral infections, treatment of chronic oral infections, and implementation of the normal procedures. Recognition and management of initial therapy of thyroid storm, seek medical aid, wet ice packs, hydrocortisone, IV line establishment, and CPR if required. So this is thyrotoxicosis, is the severe one, and it is the most dangerous of all medically emergency conditions. Now, pregnancy, it is not considered as medically compromised patient, but pose a unique set of management consideration for the dentist. The dental care must be rendered to a mother without affecting the developing fetus. So physiology and complications, yes, fatigue, and then tendency of syncope and postural hypotension, CVS increase in blood volume, cardiac output, supine hypotension in third trimester because of impaired venous return due to the gravid uterus, anemia, reduce respiratory reserve volume due to enlarged uterus and increased demands. Then fetal development, first trimester is organogenesis. Then second trimester is safe and feel good. And then third trimester, eclampsia and premature labor chances. So dental pregnancy is a very special event in women's life and an emotionally charged one. Establishing a good dentist-patient relationship is an integral part in successful management. Such relationship decreases both stress and anxiety for both patients and the dentist. So in dental management, we consider the medical consideration, preventive programs, treatment timings, dental radiographs, and drug administration. So anesthetics use in pregnancy, yes. Risk less. Lactation, yes. Then in aspirin, use in pregnancy with caution. Postpartum hemorrhage chances are there. In acetaminophen, can use, and in lactation, yes, it has a function for that. And opioids do not use in pregnancy. It has effects on respiratory depression. Corticosteroids can be used both lactation and pregnancy. Antibiotics, penicillin, then erythromycin, tetracycline, benzodiazepine, and barbiturates are not used. Then next is HIV or AIDS. AIDS is an infectious disease transmitted predominantly by intimate sexual contact or by parental means. In 1986, WHO labeled the virus as human immunodeficiency virus. Blood, semen, vaginal secretion, and breast milk are the only fluids to demonstrate the transmission of the virus. So categorization of HIV exposure: grade 1, immediate post-HIV exposure, asymptomatic but may undergo seroconversion. Grade 2, progressive immunosuppression, symptomatic like weight loss, PGL, oral candidiasis, fever, diarrhea, etc. And then grade 3 is full-blown AIDS, Kaposi sarcoma, Wessing syndrome, lymphomas, CNS symptoms, etc. Lab findings: altered T4 T8 ratio, decrease lymphocytes, anemia, delayed allergic reactions, ELISA positive, Western blot positive, then polymerase chain reaction positive. Consult with the physician. Need of prophylactic antibiotics. Provide dental care with optimal precautions. Inform all the personnel working on the patient of the relative risk involved in their minimization. Treatment of oral lesions of AIDS: candidiasis, systemic and topical antifungal agents, hairy leukoplakia, acyclovir 2 to 3 gram per day. Then RAS, topical X-fungal with Orabase, xerostomia, artificial saliva, fluorides, ANAC, oral prophylaxis, and metronidazole. In Kaposi sarcoma, debridement, prophylaxis, and intranasal vinblastine radiation. So one oral or dental surgeon may be the one and the first to aid the diagnosis in various disease. Wide open eyes, mind help us to counter any emergency that may arise in the dental clinic. In a well-prepared office, it may be possible to counter any exigency that could raise a ugly head. So with this, we are concluding this. Okay, of medically compromised condition. If you have any confusion, you just WhatsApp me and your questions are all. Okay.